Welcome to the Pleural Effusion presentation. So when we're looking at pleural effusions, we're looking at fluid that builds up or things that build up in the pleural cavity in between the visceral and the parietal pleura. And so this is where the lungs sort of get restricted in their movement, obviously, because something's sort of crushing that lung tissue in there. So that's why I put when the lung receives a hug. Not so welcome in this case, but when you're looking at pleural effusions, something's in there. So what's helpful is understanding what kind of pleural effusion it is, and that's why we'll sample it sometimes or look at other factors to sort of determine if the fluid will resolve on its own or reabsorb on its own versus us having to actually drain it. Okay, so obviously I put a picture here of Casper, and there's a reason for that. When we're looking at pleural effusions, usually this is fluid accumulating in the pleural space. It's the definition of pleural effusion. If it's infected, it's called an empyema, right? It's going to usually be some sort of thick stuff that's in there, high in protein. So infected fluid usually leads to what's called an empyema. And when you're looking at CPT, I challenge you to look at chest physiotherapy and tell me what are the indications with CPT as it relates to an empyema. You tell me on this one, right? That might be something I and or your therapeutics teacher might ask you about. Just asking, because I've had some patients with empyemas and they order CPT, and you tell me, is that appropriate or not? Why? All right, so with this, fluid separates the visceral and the parietal pleura, like I was talking about before. This will compress the lungs, right? Cause that compression atelectasis. Once again, it causes compression atelectasis, compression atelectasis. Just saying. And this can also impede the great veins as well. They might have ankle edema and all that stuff because it's compressing the vena cava as well. Right, and that's more in the severe cases down the road. So the two general categories is transudative or exudative. So I always think of transudative as low in proteins and translucent and see-through and not caused by infections. Like this is more of like your excess fluid that you can sort of see through. It's translucent, and that's why I have the friendly ghost here going on. So when we're looking at transudative, that's sort of my mental picture that I have. Oh, it's clear, it's simple, it's not caused by infection, there's no evil thing to it, it's friendly, right? Even though it's not friendly as far as physiologically friendly, it's not evil as far as an infection goes. I don't know if that makes sense. But this is when I think of a transudative pleural effusion, I think of low proteins, no infection, pretty see-through, pretty movable. Exudative, high in proteins, usually infection related, and then we'll have to sort of treat that as well. So when we get into this, so this is the transudate versus exudate. When we're in the transudate, fluid from the pulmonary capillaries moves into the pleural space. Sounds a lot like CHF and pulmonary edema to me. You have this thin watery, that's why I have the friendly ghost over in the last slide. Not a lot of red blood cells, so very, very few red blood cells, and very low in protein. So take a wild guess what big thing we're sampling when we get a thoracentesis. Right, we're going to send it for not only culture, right? We want to see what it's growing or if it is growing something like an infection. We're also going to look at the protein content. If protein content's above a certain level, then we know it is exudative. If it's low, then we know it's transudative. So that's going to be a key thing here on this slide. Pleural surfaces usually are not involved in the production of this, so this is more just like fluid overload that happened through the lymph system, right? Like with a pulmonary edema, right? We talked about a little bit of this in the pulmonary edema PowerPoint. Exudative, usually caused by a massive amount of inflammation going on, infection, or malignancy. We're looking at lung cancer patients that can easily develop pleural effusions. And I talked a little bit about lung cancer patients getting pleural effusions in the lung cancer presentation. So this is something that you're sort of going to see a little bit there. They're going to have a higher chance with malignancy in with exudative pleural effusions. High protein levels, once again, that key thing is we're going to check the protein level of the thoracentesis or the sample that we're getting. These can be loculated, fancy word for if it's in the right lower lobe, it stays in the right lower lobe, right? It's like Vegas, right? It stays in the left lower lobe. It's going to stay in that area, so it's loculated. It's locked in to that area of lung. Unlike the transudative, if I lay you on your right side, then that fluid's gonna fall down and then be taken to the area of gravity. If I sit a person up, then that fluid's gonna fall down to the bases and be taken to that area of gravity, right? It's gonna move around. With exudative, if I have it at my base and I lay that person down on the right side, it's not gonna move. It's still gonna be at the base. Right, so you're going to see a difference there between the transudative and exudative. All right, anatomic alterations. I love this picture looking at a crushing lung injury. So you're going to have that compression atelectasis. Remember, something is squeezing the lung from the outside. Can compress the great veins. That can reduce cardiac output. Also cause ankle edema. Right. It can cause a lot of the blood pressure issues to decrease venous return and elevated work of breathing, of course, because they're going to have to work harder just to generate that somewhat of a lung expansion that they can do. Risk factors for pleural effusions. Congestive heart failure is going to be one of your big ones. So let me ask you, congestive heart failure going to be more transudative? Right, thin, watery, lymph overflow, pulmonary edema type, or exudative, infection, inflammation? High protein. Which one? Hopefully you said transudative. Hepatic hydrothorax, that's secondary to the liver, right? So heart, liver. Dialysis, peritoneal dialysis is where they put fluid in the abdomen cavity and pull it back out. This is all something else. Nephrotic syndrome, once again, we're talking about kidneys, so non-cardiogenic pulmonary edema, so you can take a wild guess. Transudative or exudative here. Pulmonary embolism, we talked about this in PE and in the pulmonary edema or infarction. We talked about that there. So transudative or exudative. Bacterial pneumonias. Ooh, transudative or exudative. Looks like an infection to me, so which one would that be? Tuberculosis, bacterial infection, so transudative or exudative. Fungal disease, transudative or exudative. Looks like an infection to me. Empyema or pus. Looks like it might be high in protein, so transudative or exudative. Ooh, Kyle. Huh. Transudative or exudative? A hemothorax, right? This is usually because of a chest trauma, so especially if you work at a trauma center, level 1 trauma center or high level trauma center out there. This is something that you should be aware of. So chest trauma, do you think that would be transudative or exudative, right? A hemothorax. We're looking at blood. Which one do you think it would be? All right, so a patient comes in with a pretty significant pleural effusion, or you get called to go see a patient that has a pleural effusion. What would you see? So mentally put your Pima scrubs on, your Pima stethoscope. What would you see? And so sometimes these patients exhibit chest pain, of course, a lot of pressure because their lungs are being squeezed from the inside. They're going to feel short of breath. Usually their coughs are going to be dry, non-productive coughs. That's what that DNPC is. Dry, non-productive cough, right? It's just going to be that dry sort of hacking cough. Tachypnics, they'll be breathing fast. Heart rate will be going fast. Blood pressure, they'll have that stress response because of the cyanosis that usually, remember, triggers this triad of craziness. Tracheal shift, ooh, we talked about this in the pneumothorax presentation. Remember, this is outside of the lung, so the tracheal mediastinum will deviate towards the opposite side. So if you have a massive pleural effusion, right, here's the lung, and here's a normal lung, chest wall. massive pleural effusion on your right side, the trachea is going to deviate towards that opposite side, towards that left side. Because remember, everything's getting pulled. So when this patient's breathing, most of the gas is going over here. And this is if they were in positive pressure ventilation. So it's going to go towards the opposite side. Decreased firmness, of course. Dull percussion note, very flat because there's a lot of fluid going on here. Breath sound is going to be very distant or diminished. Point of maximal intensity might be displaced, especially if they have pretty large pleural effusion. Pleural friction rub, especially in more of your exudative pleural effusion. X-ray. So we're looking at an X-ray of someone with pleural effusion. The CP angle is going to be one of the first things you look at, right? Remember, if you're doing the A through I technique that I subscribe to, apices and then B is bases, and bases is where we look at the CP angle, because I want to see if there's a meniscus sign there or something like that going on. So that blunting, right? Normally we want to see those good arches. If we just see a flat angle instead of an arch, that means it's blunted. There's something going on there, either hyperinflation or fluid just hanging out in there. We'll look at some of the x-rays here. So the depressed diaphragm, that's what we're looking at here. It has nothing to do with its mental feelings, but I could see where it would cause the diaphragm to not feel very, very well. So maybe it does have a couple things to it. Mediastinal shift towards the unaffected side, right? Stranger danger, it goes away. So it goes, if you have a massive pleural effusion over here on the right side, you'll have that mediastinal shift towards the left. Atelectasis, of course. Meniscus sign, we'll look at that. And I showed you that a little bit in the like when we talked about re-expansion pulmonary edema with the pleural effusion over in the pulmonary edema presentation, right? So I'll show you some more here too. Fissures might be highlighted as well, especially if it's loculated, which would be your exudative pleural effusions. All right, lateral decubitus is key word because on the board exams they'll ask you which of the following type of x-rays would you recommend for someone with this? And so one of the things they're going to ask is they're going to want to know is if you know when the lateral decubitus is indicated. That's where you lay the patient down on the side, and I think I have an example of that in here. And you look for a meniscus sign, you look for that water sign. And I think I've showed you guys those x-rays before. And you're looking for that water sign. If the right side is down, then this whole area is flat, and that would be your area of fluid. And then they can sort of measure the volume there and see, oh, it's a 2-liter effusion or something like that. So they're going to put the person in a dependent position. So let's just say this is the right lung. So they're laying them right side down, like they're laying them down to sleep. And then they're going to take the x-ray and see where their meniscus sign is and how much there is in there. Okay, so this is an x-ray, I believe, from your book. This is a right-sided pleural effusion, so if you look at the apices, nothing wrong there. The bases, that's where you see that blunted angle on the right side. That's that flattened diaphragm, right? And this patient has a pneumothorax also going on with the pleural effusion. So not only do they have air in their pleural space, they also have a bunch of fluid in their pleural space too. So this person really has a lot of stuff crushing their right lung. Not good. Now obviously you can see the increased radiolucency of their left lung because gases cannot flow into their left side, so cannot flow into the right side, so it's going into their left side. It's pretty crazy. So the right-sided CP angle, if you look at this, you can barely see it because it's so hyperinflated. You can see the gas bubble. Let me get my yellow out. You can see the gas bubble here, and so you can sort of see a little bit of that CP angle on her left side, but yeah, not much. But you can see how radiolucent this is, and then this is radiolucent too, but it's because there's free air, and then this is radio-opaque because this is all filled with fluid. pretty crazy stuff. So that means that this whole right lung is just being crushed on this patient. But that's that sort of lateral angle that you just sort of see lost, and that would be that flattened hemidiaphragm and that depressed diaphragm. Okay, this is a lateral decubitus, right? This is where they put the patient. They laid them down on their right side. You can see the heart outlined here, the aorta. And so you can sort of see here the meniscus side. And then this would be their chest cavity here, right? So you're looking at all this free fluid that's hanging out in here, right? And so this is a patient, they're lying, it's called the right lateral decubitus view. They're laying down on the right side. And you're going to see that water density, and this is what's known as a meniscus sign. And it's just showing that fluid is even significant enough to go into the lateral fissure, if that's over there. So it's a pretty significant one. This one moves around when the patient's in a different position. So this one would most likely be transudative, just based upon what we're seeing here, but I have no further information on what's going on. Okay, so those are just a couple of x-rays of pleural effusions. Sometimes they'll see it on ultrasound too. They'll just use the ultrasound, and they'll actually use ultrasound to drain it, like a thoracentesis and stuff like that. So patients with a pleural effusion, what will happen with their PFTs? Well, their volumes will be low. So volumes and capacities will be low. Anything with their flow rates, well, if they have normal baseline pulmonary function values, like they don't have COPD that's baseline or anything like that. So we're assuming just a pleural effusion, they're going to just have low volumes, normal flow rates. And like I said, this is not something they come into the ER tachypnic, tachycardic, right? All that bad stuff going on. You're not going to be doing a PFT on that person. You'll be probably doing a blood gas to see how severe they are. The PFT will help you sort of, once they're stabilized, determine the severity. When you're looking at a blood gas, if it's a very small pleural effusion, usually you'll have that alkalosis. Remember, that's the cyanosis causing increased respiratory rate, all that good stuff, right? And then if it's a large pleural effusion, then you'll see that respiratory acidosis. It's restricting the lung from really getting good ventilation and oxygenation. All right, this is a shunt-like process, which means oxygen therapy definitely indicated for this patient. Will it treat them as far as like reversing the cause? No, but we're looking at getting them stabilized so their body could start to reabsorb that fluid and or wait for the other therapeutic interventions. DO2 is decreased because we're compressing and smashing the lung tissue. Therefore, our CCO2 is low. Therefore, our CaO2 is low. And when our CaO2 is low, our DO2 is also low. Our metabolic rates, consumption and A to B gradient, usually normal. If it's severe enough where we're causing hypoxemia on a high level, then obviously our A to B gradient might actually be elevated, but that could be true of almost any of them. O2 ER is increased. We've already talked about this in all the other processes. And SVO2 is decreased. So notice nothing much has changed with this between most of the disease processes so far, except for when we talked about increased metabolic rates with things like cancer or infection. When we get to hemodynamics, usually it won't affect your blood pressure or hemodynamics until you get to the large side of things. So that'll be the key thing. If I ask you about a minor, very light pleural effusion situation versus a large pleural effusion situation, that's what you'll be looking at here. So let's look at right-sided heart pressures. First, CVP, right atrial pressure, mean pulmonary artery pressure, pulmonary vascular resistance, and right ventricular stroke work index. All of these, of course, are increased when we're looking. So we have a lot of pressure on the right side of the heart going on. That's why anybody with pulmonary issues, they might have right axis deviation on their EKG, as well as having a higher propensity towards right-sided heart failure. When we're looking at left-sided heart pressures, wedge pressure is low, cardiac output's low, stroke volume's low, Stroke volume index is low, cardiac index is low, left ventricular stroke work index, which is how hard the left ventricle has to work, is low, and systemic vascular resistance is low. So all your left-sided heart pressures are low. And a lot of this has to do with crushing the blood, the blood vessels. That's why these right-sided pressures are increased, not because there's a lot of blood. They're increased because what happened with the blood vessel? We had a normal-sized blood vessel, and then it became very narrow because we crushed it, right? We put a lot of pressure there. Well, yeah, the pressure is going to increase because volume decreased. Yay, right? That's a law that we learned. Pressure and volume vary inversely. So pressure increased, so right side heart pressures are increased. It's not because there's a lot of blood going in there. It's because the vessel got smaller. So we don't have as much blood being delivered to that left ventricle anymore. That left ventricle has very poor delivery, and so therefore your left-sided pressures are going to decrease as well. All right, so how do we diagnose pleural effusions? Well, lateral decubitus is the big thing that the NBRC hospital wants you to look at. So they'll lay them down on that side. If it's greater than 300, usually, if it's less than 300 milliliters, usually it can't be seen in an upright patient because of the diaphragm and everything. They'll still have the CP angle. It's just going to be very, very minor. It's going to be hard to pick it up. But moderate pleural effusion, usually around 1 liter or so in the upright position, they'll see increased density at the CP angle. So if you're seeing the CP angle, right, if you're seeing the arch start to be flattened out a little bit, that's a sign that they might have at least 1 liter of blood, or 1 liter of fluid, whether it's blood or free fluid in there. As the volume increases, it's going to go up and create a meniscus sign. So remember that x-ray we were looking at where the diaphragm was way up here, right? And all that fluid, that lady that had the pneumothorax and the pleural effusion going on at the same time, pretty bad. So that was way over 1 liter. That probably was at least 2 to 3 liters on that x-ray. Pretty crazy, if not more. They can do an x-ray, so lateral decubitus will be a lot more sensitive to it. CT scans obviously can help us out. If the patient can tolerate lying down, that's going to be the big thing here. Remember, orthopnea can happen with a CHF patient, which can cause pleural effusions. Ultrasound, like I said, this one can be used at the bedside, most emergency rooms and ICUs. MRIs can detect this as well. It's just not typically ordering an MRI because we think a patient has a pleural effusion. Not a typical order you're going to see out there, but you can see it on MRI. All right, transudative versus exudative are differentiated by looking at what's in the pleural fluid. Okay, when we're looking at the pleural fluid, one of the big things is going to be looking at the protein in the pleural fluid. So if we're looking at the pleural fluid and the protein is pretty high, then we know it's a exudative. If we're looking at exudative, and it's more likely that it's an infection that caused it. If we know the protein level is low, then we know it's more transudative. It's more likely just edema or free fluid that's causing it. So when we're looking at interventions for these patients, the best way is to direct the treatment to what's causing it, just like any other disease process. Yeah, I'm going to give you therapeutically what you need. Yes, if you need oxygen, I'm going to give you oxygen. Is that going to reverse your pleural effusion? No, but it's going to help keep you alive until we can fix that issue, right? So we need to fix what's causing it, but we can't stop at our therapeutic interventions, right? We got to be also therapeutic to the cause. So one of the big treatments, and that's why I have that picture there, is for a thoracentesis. That's usually one of the more common things. So this is if it's greater than a 20%. Remember we talked about like a pneumothorax. If it's greater than 20%, we have to treat it, or we should treat it. Same thing here. If it's less than 20%, they may not treat a pleural effusion. They may just let it sort of resolve on its own, let the lymph tissue naturally reabsorb it. So if it's greater than 20%, we usually have to do something. And most commonly, they'll do a thoracentesis. That's why I have that picture there. So chest tube, Fourth or fifth intercostal space, mid-axillary. Patient will be sitting up, and there's some good YouTube videos of thoracentesis out there. So if you have some free time, or if those put you to sleep, then you're having trouble sleeping tonight, there you go. You could try pulling up one of those videos. I think they're interesting. I love pulling those up, but that's just me, I guess. They're going to use these either a 36 or a 28 French tube. So if they ask you to get one, or you're at the head of the bed and you're near the cart that has it, that's what you would be grabbing at. Oxygen therapy, of course, because the lungs are getting crushed. Volume expansion therapy is going to be helpful after we resolve it. For sure, because remember, low volumes, the lungs were crushed, and so that's going to be very helpful to get their lungs re-expanded overall, because remember, they lost a lot of that surface. They have the lungs, they have to overcome that 50 dynes per centimeter surface tension just to re-expand that, so they're going to need some positive pressure or volume expansion therapy. Non-invasive and mechanical ventilation is needed, of course, in severe cases. Pleurodesis is where they actually adhere the visceral and the parietal pleura together, and they do this with, I think I've seen them in lung cancer patients where they'll do this. CHF patients, I've seen them done in CHF patients as well. They actually adhere parts of the visceral and the parietal pleura together. Either they go in there and they scar it up, they like scrape it up so they both just sort of scar together, or they put this like powder in there that sort of adheres them together. And then obviously if those are both adhered together, then you do not have the opportunity for a collection of fluid there. And so that's just a treatment option. You can learn more about those. I'm just trying to get you into the disease part and not as much into the therapeutic part, because you have a whole class about therapeutic parts going on there. So pleurodesis is a therapeutic intervention, usually for a long term for recurrent conditions like a CHF and stuff like that. Thoracentesis, just for that one-time thing. Like I said, usually we'll run it for that protein content, see if it's infection related or not. All right, review questions. What are some common lung alterations that occur with pleural effusions? All right, put your Pima stethoscope and your scrubs on and put yourself mentally in a hospital somewhere. What might you find in a bedside evaluation of a patient with a pretty large pleural effusion? Tachypnea, tachycardia, cyanosis, hypertension, hypotension, JVD, breath sounds, heart sounds, tracheal deviation. Would they have a dull percussion note or hyper-resonant percussion notes? What about their x-ray? What would you see on their x-ray? What type of x-ray do you think they want to see, especially if you're working at NBRC hospital? If it's very mild, what would their ABG be? If it was severe, what would their ABG be? What about oxygenation? What type of process is this? What happens to your delivery of oxygen? What happens to your consumption? Especially if it's an infection. Ooh, what happens to your consumption? PFTs, if you were to do a PFT on someone that was stable, post all this stuff, and you're trying to see how severe they are for how aggressive to do your therapies, you're doing a PFT, what would you see? Volumes, flow rates, what would be low? Both of them? What types are there? Right? What are the two categories, and how can I tell the difference between the two? All right, give me a therapeutic intervention or a couple of therapeutic interventions that we can do for pleural effusions. What about one that's just going on that we can also sample from, or one that's a long-term to stop fluid from accumulating? So hopefully you got it.